My name is Caitlin Schmidauer, and I am in the Psychiatric Nurse Practitioner program at Eastern Kentucky University. The problem I have chosen to study is self-mutilation in adolescents. Self-mutilation is defined as the intentional act of tissue destruction with the purpose of shifting overwhelming emotional pain to a more acceptable physical pain. My target population are adolescent females ages 13 to 17. I specifically chose this group because according to the CDC, in young adults ages 15 to 24 years old, there are approximately 100 to 200 attempts for every completed suicide. The American Foundation for Suicide Prevention estimated that while males are 4 times more likely than females to die of suicide, females attempt suicide 3 times as often as males. This is an important topic for future nurse practitioners to discuss because in 2006, Puskar and colleagues found that treatment options for patients who present with self-harm vary from inpatient psychiatric care to being discharged home with follow-ups. Specific treatments may include group therapy, individual therapy, medications, or stress reduction management skills. Unfortunately, the long-term prognosis for patients who self-harm is poor because the behavior is a learned coping skill that most adolescents are resistant to change. In my literature review, I reviewed 6 Level 2 studies, all of which compared cognitive behavioral therapy, pharmacotherapy, or therapeutic intervention for the treatment of self-harm. None of these studies could prove a substantial benefit from using cognitive behavioral therapy versus an antidepressant medication. The other 2 studies I reviewed were qualitative studies that discussed patients' experiences with self-harm. Both studies discussed a need for patients to feel like they were in control in order for their symptoms to resolve, so it can be connected that cognitive behavioral therapy would be helpful for the treatment of self-harm. Kuhl, Meigel, and Bosman had some participants respond that medication use actually hindered their progress because it made them feel like their emotions were blunted and caused a loss of connection with themselves and others. Both qualitative studies, although very interesting and informative, were too small to be statistically significant and did not have any definitive answer to why patients stopped harming themselves. For my proposed pilot, 80 participants will be recruited from Nationwide Children's Hospital Adolescent Clinic. 10 physicians and nurse practitioners at the clinic have agreed to screen every patient that fits the target population for self-harm during well-check visits. This will be done from a loose script. If patients agree to participate, they will be given the choice of a prescription for cognitive behavioral therapy, a prescription for Zoloft, or both. Their medical records will be tracked through 1 year. Specifically, medical records will be flagged for hospitalizations or urgent care visits for self-harm incidents, the length that patients participate in the chosen treatment, and coexisting substance abuse problems. After 1 year of tracking, a mean score of the various appointments will be calculated separately, and a comparison will be made using paired t-test for a statistical analysis. All patients deserve the right to autonomy and privacy, but it is an ethical obligation of healthcare providers to assess patients for self-injury. My hope is that this project can provide one more piece of information to be considered when treating adolescents for self-harm. Thank you.